Morning, everybody. We're so grateful that you're here.
All right.
It's,
You want to
you're
enter?
spending it eating breakfast or something else, but you're here to learn about violence in the workplace.
You want to start with an intro?
Oh, yeah.
I did it
My name is
alphabetically.
Sally Alvarez. I'm the Director of Wellbeing at Stanford.
I'm Susie Bentley. That's me. I'm the Chief Wellness Officer at Elmhurst in New York City.
I'm Amanda Deutsch. I'm the Director of Wellbeing at Thomas Jefferson University.
We put her in quarantine because she's sniffling. Like we're not getting sick
Thought about
today.
how funny that is.
I'm Marla Doring. I'm from Indianapolis, Indiana University.
Lord.
I'm Vitas. I'm one of the assistant program directors at Stanford University.
Hi, I'm Laura Napoli. I'm the Chief Medical Officer at Elmhurst Hospital.
All right. So, as Ellie said, we're so happy that you all are here. We were saying this is a pretty challenging time slot on the last day, but the fact that you're here means a lot to us. So before we really started and got into this, we wanted to approach this with honoring the topic and how challenging it can be to talk about. And I think because it is so sensitive and hard to talk about, that's all the more why we need to be talking about it. So we kind of proceed with a very, I hope obvious, but very major trigger warning. This QR code that is up here leads to resources and references. We know that, talking about this can be triggering for a lot of different reasons. We all, especially in EM, I think, come with probably objectively large amounts of baggage for a lot of different reasons, and things stick with us differently. And that's why we're here today, to try to process some of that, share some of that, and really kind of sit in the proverbial mud of experiences like this. But I would imagine this topic probably has hit home for everyone. And, the tissues Amanda actually did bring. So if anyone needs one, she will likely share it. But again, I hope people are familiar with Stop the Stigma EM, but a very big campaign really around talking about things and trying to normalize vulnerability and being human and the experience of delivering care. So that's really why we're here today, is to normalize these discussions and just to facilitate safe spaces to talk about them. And sometimes I will personally say I feel very hopeless trying to improve the situation around workplace violence, but there is a lot of hope, and we hope that we can frame this a lot around solutions and hear from all of you things that are working and things that you're doing or you've heard about. So. With that, our learning objectives, we're going to define workplace violence in the emergency department, shared mental model, just make sure we're on the same page, talk about prevalence forms and the impacts, identify key barriers to reporting, which ultimately translate into barriers for fixing and working against, describe the effects of workplace violence through real stories shared from our colleagues that have been victims of workplace violence, and then again, really discuss actionable solutions and maybe together even come up with some new ones today. So to start us off, I put up these signs, one of which is from our home institution. I would guess, and maybe by a show of hands, does everyone now have signs to this effect up at their institutions? So these signs are awesome, and I will say I find them personally a little triggering, because it's great that everywhere is plastered that it's a felony to inflict injury on a healthcare personnel. We're in the ED, right? We can't fire patients. We just have to keep doing benefit of the doubt, and a lot of people come in psychotic. Whatever it is, no one signed up for this. This should not just be, quote, part of the job, but yet we know it's not as easy as just it happens and then they're cuffed and taken out. So things hit a little bit differently. I think the laws sometimes apply a little bit differently. And again, this is the lived experience, I think, of everyone, not just in EM, but outside also. Everywhere, the front page, something horrible is happening surrounding this. I think it's good that it's getting some press, but I think it's also very, very hard living this day in and day out. So let's start with some definitions.
So while, we typically think of violence as like a physical violence, really workplace violence, as kind of defined by the National Institute of Occupational Health and Safety, as well as OSHA, is really any act of threat of physical violence, harassment, intimidation, or other threatening, disruptive behavior that occurs at work, which I feel like a lot of us who work in the emergency department could probably think of that happening pretty much every shift. to help classify the problem and kind of shift the definition and better kind of describe the problem, the National Institute of Occupational Health and Safety has adopted this new classification of 4 types. So type 1 being criminal intent, like a robbery in the emergency department or something like that. But I think the more frequent one that we all experience is type 2, which is client or patient becomes violent while being served. Type 3 is worker versus worker. So this would be kind of the disruptive behaviors that occur between colleagues. And then type 4 is more personal relationship with an intended victim. So domestic violence or someone coming into the emergency department purposely targeting an employee or colleague.
Does someone have the clicker?
I have it.
Okay.
Want me to click? Just say click.
Sure. Okay, so obviously the scope of the problem is really, I think, pretty understandable to most of us, that it's really multifactorial with our job of why this is occurring. We have people that come in acutely ill, we have intoxication, we have people in their worst moments with the family members. It's so many different reasons that this is occurring, and as Vitas just said, we know that it also is not just the physical violence that so many people think of, but the little things, the little microaggressions, the harassment, and there's really a lot of underreporting. But what we do know is there are a lot of stats about this. Oops. So 91% of emergency medicine providers responded that they have been threatened or attacked in the past year. And 71% believe that that is increased and worse than last year when ASAP pulled its members in 2024. Recently, there's a systematic review that talked about that 77% of all emergency department staff reported some kind of exposure to workplace violence. And then in a large urban ED, again, when they were asking staff, they said they experienced some form of workplace violence once every 3.7 shifts, which I think is, again, probably underreporting that, if I had to guess what we all think, and that 25% of those did actually include physical violence. And then most recently, we know when we look at the Bureau of Labor, and this is, I think they last updated in 2018, so it is old data while we know everything's on the rise, that 73% of all non-fatal workplace injuries are to healthcare workers versus every other type of job that's out there. So we account for the most. And we, like I just said, unfortunately, we lead in this non-fatal workplace injuries. We're 5 more times likely to experience workplace violence just by being a healthcare worker, which, of course, is a 20% increased risk of becoming a victim of workplace violence. We're 4 to 5 times more at risk than any other type of job out there once you've decided to go into healthcare. And workplace-related injuries are 4 times more likely to see people taking time off from their job. So these numbers matter because we know we already are having a retention problem, and why would people want to work if we can't protect them? So again, this kind of speaks to what we already talked about in different ways, that we know that workplace violence is on the rise. We've already gone over a lot of this that ASAP has found. People are seeing it more. It's being reported a little bit more, and unfortunately, we know that these numbers are just increasing in healthcare.
Okay. So I've been given like a couple of minutes to talk about the impacts of workplace violence, and the impacts are significant and they're multifactorial. So there's no way that we will touch all of this during the next 2 minutes. So this is just really an overview. Basically, how many of you guys can relate to this quote from one of our ED nurses? So I think it's important to realize that it's not necessarily the major like physical assaults that are only impactful. Even the smaller, as we mentioned before, kind of microaggressions or offhand comments, abusive language, all of those things can add up in a cumulative way over time and impact our colleagues and ourselves. And even though something may not on paper look like a significant event, depending upon the kind of day that you're having, your own lived experience, something that's said to me might fall differently on me than someone else. So I might perceive it as a more severe impact versus one of my colleagues. So it's really hard to predict how a particular incident is going to impact an individual worker. So I don't know how many of you all are familiar with the quintuple aims. So it's basically a framework that focuses on improving healthcare delivery and the sustainability of healthcare systems. And I don't have time to go through all of this in detail, but there are 5 different aims, which are listed here. And each one of these aims, the impacts of workplace violence will touch all of them. So I think we can use this language, which our hospital administrators and hospital leadership, this is kind of how they speak and what they know. And we can use this framework when we start to talk to them about actions and solutions. And then finally, kind of dialing it down to the individual human being. So our colleagues, ourselves, realizing that workplace violence incidents result in significant mental health and well-being impacts. So PTSD, anxiety, depression, decreased job satisfaction, increased turnover. So it affects the individual, it can affect patient care, and it can affect organizations. So when we think about all of those things together, I think it can really motivate us to take the next step, which is to talk about decreasing barriers to reporting and working on action.
So we've talked a lot about underreporting, right, which leads to underaction, essentially. So really, what are the root causes, the compounding effects, the barriers to progress here? So very multifactorial, like most things that are complicated. So one of the biggest issues, I'd say, why we have the inaccurate data because of underreporting is around the variability in the definitions. So staff vary, I think especially in EM. So is workplace violence just physical abuse? Is it verbal abuse? Is it both? And even if we polled the room, I think people vary on what they would define it as, despite the fact that ultimately, when we take off our EM hats and our doctor hats and we look in from the outside, it is all workplace violence, right? And it is all unacceptable, but we've gotten to a place where it's been so normalized that perhaps we've gotten almost a little bit not used to it, but it's kind of clouded our ability to judge and to see how bad all of that is, no matter what type. So again, how you define it matters, because if you don't think it's violence, you're not going to report it when it happens to you. So all violence is inherently aggression, but not aggression is violence. Violence is aggression with the intention to cause harm. These constructs, I think, are part of the problem, and violence in and of itself is actually more of a legal or a police term. And that matters in terms of who gets cuffed and who you can press charges against. It doesn't matter for the lived experience. And I don't know about you, but sometimes I think I would almost rather be punched by a patient than have to endure some of, the onslaughts of verbal abuse and discrimination and degradation, that happens in the ED. And again, none of it is acceptable, but when we start to weigh it differently and look at it differently because of the language that we use, I think it leads to a very tricky place. But again, it all needs to be reported, because with real data, we can actually show up differently. So we can't prevent all of it. I think that would be a whole different talk and probably the keynote if someone figured out how to make that possible. But we can show up differently, and the only way we can show up for people after it, the part that we can control, is if we know that it's happening and we have those trends, right? And that's why reporting is so powerful, but remains such a problem. So we did a big initiative around trying to understand why people weren't reporting, and these were just a few of the quotes that stood out that I wanted to share when we talked about it. And ultimately, it got into 3 main drivers, and it was really how, why, and is it safe to report? So, that yesterday I had an x-ray, I'm fine. Let me tell you about 5 years ago. I wasn't really that hurt. Who looks at those reports? I wouldn't know how to report. Will my supervisor be upset, right? This all speaks to the problem and how normalized this has become in a very, very sad and strange way. But again, so how to report? It's really moral injury to have to fill out more paperwork, right, on top of all the paperwork we do. But it's the why, the skepticism that nothing changes, right? Anyone hear that? Like, why would I report? Because no one's listening, no one cares, nothing changes, right? And then, is it safe to report? Will there be retaliation? Will my whoever be upset that I've actually filed the incident report? All of that together, that's why we have underreporting, and that's why we had the huge amount of enduring moral injury camaraderie that comes from being in a place where this is happening frequently, and we don't feel empowered or like we matter enough necessarily to even report it, to have someone be able to take action for us. So we would like to open it up and do a reflection, but basically to start, we wanted to share some stories. We know that the numbers are grossly underestimated, right? But this epidemic of workplace violence that we're talking about, it's really about the what and the who behind the numbers, whether they're reported or not. And I think there's a lot of power in stories, and you may be triggered by some, you may identify yourself or your colleagues in some. We'll read the stories. We're going to start, we'll read 2, and then we want to open it up and hear what resonates, what stood out to you, if anything. Again, really acknowledging that everyone in the room has their own experiences that they're bringing to this. So you don't have to share, and we're not going to ask for your own stories, but we are curious if anything does resonate, because I think sometimes, again, talking about things that are hard to talk about is actually the first step in making progress towards more of these conversations and normalizing it. So I'm going to hand off to Ellie to start.
So here's one story. It was a horrible Saturday night. I heard loud yelling in the triage. I approached calmly, hoping to de-escalate, and also for my 12 plus inches in stature over our badass charge nurse, now who's cowering. Then the patient flew towards me, punched me in the chest, shoved me into a supply cart halfway across the hallway, where I hit my head, fell to the ground. We did what we do, and together we restrained and sedated the patient so we could all get back to work. I told everyone I was fine. I laughed it off. I was much more worried about the charge nurse. I finished my shift with a splitting headache and sore neck. Police finally came, but I didn't really want to press charges or have to repeat the story. The worst part was really that I felt so embarrassed that I got caught by surprise and actually got injured. I should have been ready. I should have seen it coming. This wasn't the first time that I've been assaulted. Oh.
No, we're doing second.
I probably second, and then we'll just...
Okay, here's a second story. Not my story, but it's impactful for sure. So while caring for an incarcerated patient, he began with a colorful verbal onslaught when I started my eval. The guard made no attempt to tell him to stop. I ignored the comments and continued on with the eval, which in hindsight probably upset him more. After he moved on to telling me he was getting out soon and would be sure to come back and find me and do all of the things he was previously threatening, I tried to redirect him. I thought maybe it worked, but then I just remembered that he paused and smiled before surprising me as he lunged forward and bit my forearm, after which he spit directly in my face and asked me, "How do you like that, you dumb cracker bitch? Now I'll come back to kill you and find you by my teeth prints." The guards quickly jumped up at that point and restrained him back in bed. I will never forget how pleased the patient looked after that, or how he smiled at me, mouthing that he would kill me even afterwards. I walked directly away in silence into the nearest bathroom. I remember how afraid I was that I would cry in the middle of the ED. I washed my face and my arm, grateful that the visible ring of teeth marks largely had not broken the skin. I was panicked to go back to the ED, the nurses, my attending, and that patient, and I was really unsure what to do next. There was a knock on the door, and it was my attending. Said, "Why don't you step out for coffee for a few minutes?" I wiped my face, walked out, assured him I was fine. I was so grateful he insisted I go grab coffee. I grabbed coffee for myself and the team, and came back a few minutes later. The attending eyeballed my arm at some point later that shift, told me, matter-of-factly, that since the skin wasn't broken, no prophylaxis was necessary. And that was the last time that anybody ever mentioned this incident.
I'm curious what things are coming up for folks as we read those two cases. Please go ahead.
So I think it sounds like these were very intentional. These were patients who had control
schizophrenic,
Mhm.
and one who comes in almost daily,
Yeah.
very intoxicated. And so it's very frustrating. It's this constant cycle. This, particularly this intoxicated patient, keeps injuring.
Yeah.
I mean, it's almost predictable. And occasionally charges get pressed, and then we don't see her for a week or two. We assume she's incarcerated, and then she's back. And
Yeah.
the same cycle continues. And so I think the ones that you guys described are even more frightening because it was sort of unpredictable, unforeseeable, and it's such a helpless feeling.
Yeah, thanks for sharing that. I think that tension between there's the patients that we see that has pathology that we can almost just predict that they're going to do this just because we kind of know them, versus the ones who out of nowhere just kind of lashes out and share those acts of violence towards us. And I guess the point that I'm trying to tease out here is that none of them are acceptable, and yet somehow we seem to forgive one versus the other. And even from the law perspective, the one who has a history of schizophrenia may be a lot harder for us to then do something versus the ones who are just doing it because they purposely did it, right? And that reminder that like none of this were acceptable. We never signed up for this. There was never a part of medical school or any of our training, so like just suck it up and just move on, right? And yet somehow most of us would just see this as like, oh yeah, it's that patient who's intoxicated again. Just be careful, just watch out, just don't get too close, versus perhaps some other ways of just having security there at the bedside from the very beginning. I've also trained in the Bronx versus where I am now, where we would protect our patients, because when we would escalate a little, or the patients escalate a little bit, it was actually very dangerous, because then the security officers would close the door, and then we would have to then work up the patient afterwards with like broken stuff, right? And so there's extremes of this, but at the same time, I think the acknowledgement that, again, this was never shown to us when we were applying to medical school or residency. You had a point.
I was just going to say, thank you for sharing the stories. I think, just unfortunately, they're very typical, like, all relate to the
Yeah.
stories I've had. Texts, bitten, by violent patients. So, it's, and I recently wrote an op-ed in the Sun-Times in Chicago.
Yeah.
We had there was a physician at a local hospital that was stabbed in the chest.
That's right.
And then brought to the trauma center in Chicago. So, it's widespread, and thank you for sharing the stories, because it's important to really start talking about these things openly.
Yeah, and I can imagine it was probably not as easy to talk about that physician in the moment as well, and also talking with the team. How often do we actually debrief this thing, right? How often do we actually like pull the team aside and it's like, hey, that was not cool. Even the validation of like in one of these stories, like the one that was like shared, like that was the very last time somebody actually mentioned that case, right?
That's what I was going to say. When Marla read that story, that's what really stuck with me. And how many, when you guys practice and you see this, do we call it out? I try to now, because honestly, I think labeling it, it's usually not even our trainees or our physicians, it's my nurses that I'm watching get clobbered or just verbally yelled at. And I yell back at the patient sometimes when the de-escalation doesn't work. This is workplace violence. Unfortunately, I'm asking you to leave, and security will help you leave. But most of my colleagues don't feel comfortable doing that. But we need to start labeling it.
I've been in a position for over 3 years, so I can say that we went from the beginning where they took away the stun guns from the security because they stunned a person that broke a jaw, one of our nurses, and then that person sued the security guard for assault. So our network shows we don't want to be used for hurting patients or nothing. And then we had a couple of really bad outcomes, really, really, and not just something you need to be briefed.
Sure.
Right, it's really bad, because the world has changed.
Yeah.
In that career of mine, I'm guessing for some of us that have to be right here. This is not the same world that we started, so it's a new ground to teach. And I think what I see now is something to make us feel better. Like they have a security guard dog that goes around, so still not a weaponsmith thing, but a security dog that you're not allowed to touch, but that is going into every patient room in every area, searching. we don't security every citation or intoxicated venue belongings.
Yeah.
We don't do every person. But nobody seems to be as offended about the dog, right? And so I think we just have to keep working on systems because now since the last bad incident, like your story is, it has happened before. We now have a systems thing that flags those patients on the Epic chart. So any one issue puts the flag and security must go in that little first.
Yeah.
Even they show up at the front door. The systems is what I think we have to really look at this and be how accountable the administration or they are rare events. Luckily, it's not every day, but it could be, right?
Yeah.
And you don't know which day is holding accountable for the systems responses. So whether it's an epic change, whether it's now that we have actually police department in the department, which we never had for decades, was the township felt it was the hospital's responsibility to provide security. Now they negotiated where we actually have police on site. So I think that all of this change is because we keep talking about it.
Yeah.
We did, unfortunately, both times that we've seen change start with somebody really getting hurt. We hope to be ahead of that, right?
We should be preventive, not always reacting. And we didn't place her in the audience to say systems need to change.
I mean, I think the first story that you shared, almost the guilt
Yeah.
the provider experience, for like, I should have seen this coming.
Yeah.
I felt like this was my fault that this happened to me.
Yeah.
Like, that has to change. Like, that is not your fault. This is not an acceptable place to work. And I think, you mentioned signs. I think instead of just saying assault is a felony, it's just like a crime is still a crime.
Yeah.
You assault somebody, you still have assaulted somebody. Like this does not change because you've stuck inside a hospital. We had up until about 6 months ago, never had screening into our emergency department with metal detectors or weapons detection. We had one of our providers who I unfortunately was standing right next to when he got hit with a hatchet.
Yeah.
And somebody that security had come through and screened and searched his belongings and somehow managed to miss a knife and a hatchet. And it was only after the operating job, everybody working there was like, this is a problem, what can we do? That some of the other stories came up of one of our PPPs got stabbed in the neck a year earlier with a pen, but that wasn't talked about.
Yeah.
So I think the culture of let's start talking about this is important.
I think from a culture perspective, I think it's important to highlight as well that unlike the nurses that we work with, and again, they see this a lot more, they experience this a lot more, when they file those reports, it's during their time of work, right? So actually they step out, somebody covers them, and then they fill out all the forms that needs to happen. For us, like, there's all these other patients that we're responsible to take care of, and so like leaving is not really an easy option for us. And so that guilt, so Susie mentioned moral injury. So moral injury is it's two betrayals of the system, that it doesn't allow us to even like take care of ourselves and file the appropriate reporting to prevent this from happening again, and also the betrayal of ourselves. We betray ourselves because like I wouldn't want anybody else in the workplace that I work to go through this, and yet I am willing to just take the sacrifice because I think that like it's more important for me to see other patients, or maybe it's because I'd rather just get this done and over with because I just want to go home after this, right? And so those like compromises that we do add up eventually into these like morally injurious incidents. But you're right, that's lack of acknowledgement and even not even talking about it or not even knowing that this has happened is dangerous because it can potentially happen again. Another systems thing, I love the epic science of violent patient, right? But what we failed, at least what I've seen in our institution, and we're very focused on this as well, and we'll show you like some of the things that we are doing. We have a physician who got assaulted by this patient, and we flagged it, like the chart like screams like this is a violent patient. 2 weeks later, guess where, like of all the places in our footprint, the emergency department is the size of a football field, right? Different zones. But of all the zones to room that patient, it was with that same physician. I'm getting goosebumps because like I can only imagine what it feels like to not only be hit, not only to have to go through all the paperwork that happens, the emails, the back and forths on their day off to like respond to asking like, can you describe what happened? But then showing up to work and you see this name again, the same person that like assaulted you. And this was not a one-time thing. It just keeps on happening because there's actually no way to flag a person to say like, ooh, Alvarez is working. Don't let this person work with that person, with this patient. right? And so I think there's another element there that may be missing that we can at least think about. But if we don't talk about these types of things, we can't even figure out creative solutions for addressing that. Any other thoughts? These are really great input that you're bringing up.
We actually had one patient that was so violent, there were signs up in front, because he was not allowed in there unless there was a true emergency condition.
Yeah.
He was escorted by, I think, security and everything like that. So I think there are ways to do it. It just takes actual people willing to do it, and it takes reporting. Like, would that person have been, would the hospital have been sued successfully for assault if the doctor had actually filed charges and the DA and the cops had actually taken it seriously? Because it was them protecting, right? So I think we all need to be really good about, it's not a just brush it off. You have to actually talk about it, you have to report it, and you have to make it easy for you.
Yeah. Oh, please go
I was
ahead.
just going to say, and another common theme in these two cases is that neither one was reported.
But
And it speaks to those drivers that we talked about.
But I think that's why our next steps of what we start to talk about is we have to make it easier to report, right? We can't,
Well, unfortunately, you also can't stop, because I think we can report it as much as we want.
Yeah.
If they refuse to file charges, it's not our decision to
No.
file charges, it's theirs. And so if the cops brush us off.
Yeah, and even if they go to jail, which I have seen as well, right? Like you mentioned, they're gone for like a month, and then a month later they're back, and I'm like, what happened? Like I thought you were really gone.
And the nurses too are like, we're not gonna report it because the prosecutors aren't prosecuting.
Yeah.
Like, it's
Yeah.
like,
Yeah,
We have an interesting situation that it's not all healthcare workers that it becomes a felony, but in an emergency setting, the way the law that originally was intended to protect first responders definitely includes the emergency department.
Mm.
And we run into a situation that when it's reported to the police, they don't know that section of the criminal code. And I have some law enforcement training. They didn't teach us that at the police academy. And it becomes a little bit of a thing. These events happen, and I go and I print out the section of the law and hand people that piece of paper and say, hey, when the police come, you need to hand them this so that they know what charge is the appropriate charge. It's not just simple battery, it's also this other one, assault of an emergency healthcare worker, which in many cases under Georgia law escalates it from a misdemeanor to a felony.
yeah. I mean, that's a very good point, right? That's very actionable. Something that we can have in our department. You can create a QR code. If this happens, give the police officer this. I think that's very, very helpful. Thank you for that. Any other thoughts?
I was just going to say, we're really focusing on physical violence, but I don't want us to forget that verbal abuse is also workplace violence.
Yeah.
I think almost nobody reports verbal abuse, because if the story that I read stopped before the actual physical assault, would anyone have even attended to that at all? So I think we need to step up the reporting to include verbal abuse.
Yeah.
And to follow up, since I threw in Georgia law, under Georgia law, verbally interfering with emergency care is a misdemeanor already. Like, there's already a code for that, and it's one of those, nobody knows it, nobody files it, and, it becomes a problem of you call in an officer, and unless there's somebody like me who's like, hey, I'm sworn with your partner agency, this is a crime, here's the code section, there are 4 witnesses, let's do something about it. But I also want to be aware in the states, many states have similar language in the law. It's there, it's usually not on the signs in the hospitals because they're worried about the physical violence.
But words matter, right?
Yeah.
Yeah.
And also, while that's important, and we understand that it probably likely happens a lot more than the physical violence, and therefore we are not reporting it as often, a common experience is also that these things are happening, and the chart is so bland. Right? It's so bland. And so then when you're like reporting this later on, or worse, they complain about you because you didn't do that MRI or that one thing that they wanted, you didn't give them the pain medicine that they requested. The chart is so bland. And so how do you even like defend yourself later on? So then you're put in this situation that you now have to like defend yourself based on your recollection of the event, and none of the nurses, none of the staff like wrote anything that has actually transpired. And so I think that's another thing. Like, so for me, when things like that happen, I put in quotes, blah, 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 this happens. And then I ask another nurse to come in, because usually when they escalate like that, I just don't go in by myself, because now the two of us are writing it, right? So let's go there. Let's talk about like some solutions, best practices. Do you want to start with this, Paramit?
So some of the solutions, and of course we have a long way to go, but we have come a long way. I think that's what we're trying to highlight here from a lot of what you all have brought forward. Culture and psychological safety. So obviously you want to promote non-retaliation, normalize speaking up, leadership, visibility, and modeling. I mean, I mentioned in the beginning, I'm the chief medical officer, and I often don't even find out about these events that are happening. I think the other day I was with Dr. Bentley and my CEO, and in a side discussion, there was a mention that one of the colleagues in the emergency department had gotten hit. And this was days ago, and there was a mention that nobody from leadership said anything, but nobody on the ground told me that this happened. So I think the bi-directional communication really needs to happen, and we need to really take action when it happens in the moment and right after the moment, and not let time go by, because then it's a clear message that leadership doesn't care. So leadership really needs to be at the forefront of all of what's going on. Clear policies and reporting mechanisms. We already mentioned the EHR embedded tools. To the point that was made, they are great, but there is a piece missing, or a few pieces missing in them. I think I heard somebody say that when somebody's flagged, their hospital police automatically goes into the room when they show up. I think those kind of workflows need to be put into place around the tools, because a tool is just a tool and a flag is just a flag. So unless the actual protocols around that are in place and enforced, it's just going to be a flag. Posters, QR codes, mobile access, consistent policy reminders. I mean, constantly reminding that this is not okay, what the policy is around actions that are, assaults that are taken, holding our own staff, and this is for me, accountable to do something about it when something happens, and not let it be brushed under the rug. Response and accountability structure. Safety teams review every report, consequence pathways, staff-informed outcomes. I think that piece, at least at my institution, needs a little bit more work. That loop back to let people know that something was done when it was reported. I think there is a lot of feeling of, if I report it, nothing's going to happen anyway. So we need to make sure that there is action, and then when the action is taken, then it gets back to the person who reported, so they understand that you should report, so that we can actually address these issues. De-escalation training, we've done this at our facility. Obviously, behavioral health is mandated to do it. I don't know if it is in your states, but in our state it is. But we've also done it across the board with all staff. So invited clinical and non-clinical staff to join in de-escalation training. Environmental safety, panic buttons, security rounds. We've put these all over the hospital. Peer support and post-incident. Obviously, our H3 team, Hospital Helping Healers Heal, is run by Dr. Bentley, and she does a phenomenal job of supporting our staff. Strategies to address workplace violence in healthcare. We talked about a lot of these. So there's the de-escalation training and the self-defense upstander training. I think this is really important. You get you see a lot on social media, people filming these incidents, and really training people to not just be a passive bystander, but to be active in de-escalating and getting help, and stopping whatever is going on, and then obviously reporting it is the next piece of that. The environmental controls, we talked about the signage, the panic buttons. We have panic buttons also on our computers. We have them on the furniture. Adequate staffing. I mean, we are in a Dr. Bentley and I are in a public hospital, one of the second largest public hospital in the United States. Staffing is an issue everywhere, but yeah, we are chronically understaffed, and that is a huge problem. Security presence, also understaffed in that realm, and hospital policies. You know, a piece of paper is just a paper unless it's enforced. Obviously, governmental policies and legislation, we need to keep advocating. The U.S. Surgeon General released a framework for workplace mental health and well-being with 5 essential domains in 2022. Workplace violence directly undermines protection from harm and connection and community. I mean, I think this is really powerful words, and I'm happy that it's gotten to this level. So the Surgeon General's framework for workplace violence, for workplace mental health and well-being, there's 5 pieces to this framework. Protection from harm, which includes safety and security, connection and community, which includes social support and belonging. I think that's really important in the workplace. Work-life harmony, autonomy and flexibility, matter at work, dignity, and mentoring and opportunities for growth. So there are a lot of efforts. Staff-facing policies and procedures, reporting and standardizing administrative response to reports, standardized response systems, and de-escalation workflows. So there's a lot of legislative efficacy and advocacy going on, but again, we still need to do more. So local action examples, so actually having staff drive the change, having leadership in the hospitals drive the change is what really is going to make a difference. Why, and is it safe to report? So from staff focus group, 3 barriers to speaking up about workplace violence emerged. How to report, lack of clarity and complexity of workflows. Dr. Bentley, again, I can speak to what happens in my hospital, has really worked to streamline the reporting so that you report in one place and that report goes to hospital police, it goes to helping healers heal, it goes to risk management, it goes to leadership, so that the person who's reporting doesn't have to fill out forms in all these different areas, and everybody then comes together to address the incident. Why to report? I mean, obviously there's doubt that it leads to meaningful action, so we need that feedback loop that I already talked about. And is it safe to report? There's fear of retaliation and inaction. I remember when this was like way early in my career, and I got kicked in the chest. I lost my balance, went back. It was back in the day when you actually put the film up on the X-ray film up. So I hit the X-ray board, I broke it with my head, I fell on the ground, and I was like, what just happened? Like, it was just so, it's one of those things, you can't de-escalate an incident like that because it's such a impulsive move that the patient did that wasn't expected. And I remember the AOD came down, it was sometime in the middle of the night, and I said, she asked me if I wanted to report it, and I'm like, again, same thing everybody else, what's going to happen if I report it? I think the person had a restraining order put on them, and they were told they couldn't come back to the emergency department. Whether that actually happened or not, I don't know. But to the point that we've come a long way since 2 decades ago when that happened to me. Solutions implemented, so simplified electronic and verbal reporting we talked about, embedded reporting reminders into the EHR and safety huddles, ensuring staff-facing policies and addressing workplace violence against staff, specific workplace violence against staff subcommittee formation. We do have a committee that comes together when there is a really problem patient that, inpatient is really also an issue because we can't discharge those patients, especially when they're too sick to be discharged, but they are assaulting our staff. So we come together as a group and try and formulate a plan. Language added to policies reinforcing non-retaliation and quarterly updates to staff. That's important, that feedback loop.
I think we should skip this probably to get into more specific ones.
Great.
Yep.
So this is what we do at Stanford, because This is coming from a place where we used to be like, if somebody complains, then it's like it's a pain because you have to respond to all of that. And the Press-Ganey score was something that like we really treated seriously until we realized there's a lot of bias against actually women and historically marginalized groups. And so we actually just got rid of Press-Ganey in our institution, and we just created our own way of doing that. And despite all of those, we're experiencing the violence. And so what we've developed is there's two sections actually. So it's called, the first one's DARTS, it's the de-escalation technique. So if somebody just even's like, I will sue you, I will complain about you, right? And it's actually interfering from my way of thinking about how to manage them, I can activate the DART. So how it goes is I'll go to the charge nurse, like, this patient is really escalating. We need to like have a concerted effort to address this. So the charge nurse, myself, the attending, if it's my resident goes in there with the police with the security, with the social worker, and all like 5 teams. So, and then the primary nurse. So like each of us will go in there. We'll have a nice conversation. This is a place of respect. We respect you as a patient. Here's what we're gonna do next. We are gonna give you this pain medicine, or we're not gonna get that MRI. If you want, you can go home or go see a regular doctor. We have now cleared you from an emergency. If they ever escalate, I just step out, security takes over, they're escorted out. Each and every one of those 5 members will write a report in the chart. We flag the patient as violent. So if they ever complain about you, the entire hospital knows that this is like a significant effort, right? So it decreased a lot of these like worry about like, I'm gonna complain about it. You can complain, nobody's stopping you from complaining. But we will also empower ourselves to highlight what we have seen and what we have observed. And so we use a lot of like quotes. The BART one was just like recent because again, it was getting a lot, and sometimes actually like used too much. So like I heard like a case in the ICU, and like my ICU colleague was like, they just darted my patient. The family was just asking a lot of questions. It was truly just curious. But then the nurses were just like, I can't do my job, right? So people can also overutilize this. But the BART one is actually pretty impressive. So when it's behavioral, so if somebody actually like gets hit or they're threatening like physical violence, the nursing supervisor for the hospital for that shift will come down with their team so that the charge nurse can focus on the rest of running the emergency department, and then they talk to the patient with the security with the same expectation. This is a place of safety and respect. We're happy to take care of you, but we're not gonna tolerate this. And then we tell them that, and then if they wanna stay, and most of the time actually, it de-escalates so easily and nicely that you don't hear about it. Right? And so I think this is just a very specific way as an institution that we're addressing it, because we can keep on talking about it and the barriers, but unless there's like tooth in the game that we're all actually going to be empowered to write it in the chart as part of the patient's medical record, so then when they go to any other hospital that uses Epic, this will also be shown there.
And then I'm going to talk about just a very simple what we've done at Thomas Jefferson University right now, because same thing, we're trying to put systems in place, and we want to make it so it's easy. Part of it is that we had to really make clear that when they hear the behavioral response team, which we call it the BERT alert, when a BERT is done, they have to act like it's a STEMI or a stroke, the attendings, the nurses, everyone. We have to get there and not wait, because for a while it was like a BERT was being called in the waiting room and everyone would be like, meh, there might be the intake physician already there. We got rid of that, and we've said, everyone, it's an emergency. And so we are treating workplace violence that way. We also know that the on-pointing or the safety net, whatever it is that you use through the EHR, isn't used often because it's clunky, it's a lot. So one thing we've done is we actually created an alert now, and it's the purple highlighted one that looks like a little huddle going on at the bottom of the screen. That's our BERT alert. So maybe we're not actually getting the full on-point in, but now we can actually track in Epic when it's occurring, because just like a fall risk or the stroke alert or any of the others that you see of all our trauma activations, we now have the BERT alert going into the Epic chart as Lisa click, so that we can track that. Still also being underutilized, but we're starting to have that conversation of let's use this, let's make it easy. Even if you're not on pointing it, let's at least get tracking this more readily so we can see what's going on. And we've finally done a dot phrase, dot BERT alert, and so it's like kind of walks you through it too if you don't feel empowered, because I know LA and I feel very empowered to kick people out when we see that they have capacity and they've gotten their chance. But I've had a lot of young faculty that are newer than me that don't feel that they have that control. So the Burt Alert dot phrase, not run by legal, but our department felt we feel good about this. And it's like, did we try to de-escalate? Did we move them into a room? And are they intoxicated? No, all those things. So you can write what you did, helps it put it in the EHR a little bit in the note if you already weren't doing it. I take my time and write very long notes when I'm kicking people out or when they're being assholes, so to speak. But we can all start putting these systems into place.
So again, we're just going to hit this right home. Violence is not acceptable. We did not sign up for that. There are actually things that we can do in each of our institutions, and it can start with us just reporting it, including putting it in the chart. And I hope that we're able to give you some flavors of what we can do ourselves, what the institution can do, what we can inspire people to do, including maybe like giving them a quick handout, or like the police officers, so what they can do once they take care of these patients. I know that we're at time, and so feel free to ask any questions, take a picture of some of the resources, and again, we're really grateful for you to sharing this time with us and just engaging. Thank you.
And if you have further interest in this, we would love to make we're trying to do a subcommittee of workplace violence in the wellness committee that we offer everyone, whether you're a trainee or not. Please join us, let's make a difference.
Yeah. Doesn't have to be a heavy lift. It can just be, here's my opinion. I don't know what to do with this, but like maybe we can do something about this, similar to what you offered earlier for police officers.
Exactly. So thank you, everyone.
Yeah, great. If you need some slides for like references, it's right there. Thank you so much.
That's actually all in the QR code too, so.
Oh, cool. Thank you, everybody. Go ahead.
I know there's
Yeah.
a quick question.
Yeah.
So I know I was taking a health and safety course, and some hospitals actually include it in their quality and safety metrics, like how
Yes.
often. So is that something that you would endorse? Is that, so like when a patient falls, you have to do a safety report.
Yeah.
If a patient gets, is that?
We get a report every month in our department.
Yeah, we do, so I'm the chief wellness officer, so have the ED as well as the hospital-wide picture, and we actually added, probably within the last 2 years, into QAPI, and it even goes to our system hospital board, how many incidents of workplace violence against staff there are. So we've added it specifically as a priority metric. And I like to just point that out to the staff, that the reporting, if nothing else, is being broadcast because it makes people really uncomfortable. Just like this talk would make a lot of our administrators really uncomfortable to hear. It's like sharing the pain upward, because with those numbers and getting them embedded as something that's talked about every time at the same level as falls and sepsis alerts and things like that, you're sharing the pain and you're really making people have to do something.
Yeah.
Right? From a liability perspective, but really an ethical perspective too. So I think it's hugely important. And that's like workplace violence as an emergency. Just that's the culture change, I think, is really starting to change the messaging, the language.
Yeah, I'm the president of the Illinois College of Emergency Physicians, and we try to craft legislation to require hospitals to report acts of violence against their healthcare workers to the Department of Public Health.
Ooh, outside. That's great.
And but the hospital says
They don't want to do that. Yeah.
So
we're working on it, but our legislation got
I can imagine.
staff safety, I will say, it sounds like an oxymoron to say it's a good thing, but Joint Commission is actually probably moving towards mandating some level of
Reporting,
oversight
yeah.
with staff safety and violence metrics. And while we all hate those, well, I personally will say I hate those visits, and think it's a lot of bureaucracy, I think that that's a very powerful move. And that may be the pressure that many institutions need to actually start doing something about it. Because once you start linking it to funding and accreditation, other things, it matters.
That sounds a great piece of joke.
Yeah, I know. Perhaps one of their.
I'll write them a letter.
So, and ACGME already also has started to add a lot of pressure by requiring, a lot of language around what you're doing to protect trainees.
For trainees, for sure. Yeah, we have. That was actually the impetus for us.
Yeah.
Yeah.
But I agree, it's got to start being pressure up, pressure down, the side everywhere to
Do
change.
you train, like we have a policy where only
I'll welcome the other group to come in.
Oh, yes.
But that's okay, you say.
Keep that way.
Yeah.